Good day. This is Dr. Ahmed Medhat al-Shafai, lecturer of otorhinolaryngology, Faculty of Medicine, Helwan University. Today we are going to discuss our new topic, tumors of the pharynx and the larynx. It's quite different than the previous lectures. Previously we discussed the inflammatory sequelae, starting by pharyngitis and proceeding to deep neck space infection. Now the tumors, the neoplasia, it's our topic today. We will consider the variant malignancies in the pharynx and the larynx. To start with the pharynx, the anatomy, just a review for the anatomy of the nasopharynx. The nasopharynx, it's the post-nasal space. It's a cuboidal shape. The lateral walls formed of the Eustachian tube. The fossa of Rosenmoller, which is one of the most important landmarks in the nasopharynx, as an origin for nasopharyngeal carcinoma. This is the commonest origin for it, and the roof of the nasopharynx. It has a slope downward from anterior to posterior. Then proceeding downwards to the oropharynx. Anteriorly, it's the posterior choana and the nasal cavity. Posteriorly, it's the posterior pharyngeal wall formed by the pharyngeal musculature. And inferiorly, there is the soft palate separating it from the oropharynx. Then we will, after the anatomy, to start with nasopharyngeal tumors, the most important to discuss in the benign tumors is the nasopharyngeal or the juvenile nasopharyngeal angiofibroma. Also the malignancies, there's the nasopharyngeal carcinoma, which is the commonest. Lymphoepithelial carcinomas, which is softer and rapid growth, maybe in younger age. It's a variant of the nasopharyngeal carcinoma, and the lymphomas, which is commonest in the young age, very rapidly to grow, and there is cervical lymphadenopathy, and this one of the sites for the lymphoma to present, as lymphoma might present in the head and neck at various sites, considering the lymphadenopathy, and this will be proven by different markers and of course by the biopsy. At the benign tumors, the Thornwaldt cyst, this cyst sometimes misdiagnosed as a malignancy. It arises from the as a remnant of the pharyngeal notochord or the pouch of Loschka. Also, it's in the nasopharynx, in the midline, surrounded by the adenoid tissue. So it's a midline swelling, mostly asymptomatic, discovered by chance. It's a smooth mass. Rarely it might be infected. There might be something in the CT scan that the content of the fluid inside this mass. Sometimes it might be just changes if it's infected. The CT finding will be different than normal cyst. Also, some symptoms might present If it's enlarges and encroaching of the staking tube orifices, there might be otitis media with effusion, and also referred otologia if there is some irritation of the pharyngeal plexus. Also sometimes nasal drip. Diagnosis by endoscopy and CT scan or MRI biopsy. It's the main diagnostic feature, but this cyst usually it's excised. Usually, if there is no any problems like nasal obstruction, it can be observed without any intervention. In case of infection, we will need antibiotics, and endoscopic marsupialization and excision of this cyst, and it will be sent for the pathology to determine the content of the cyst. And the important topic here is the nasopharyngeal angiofibroma. It's a juvenile disease. Histologically, it's a benign tumor. It's fibroma with a very vascular content. That's why, hence, the name is angiofibroma. Age and sex are the main determinant. Males is the most common. The age is between 10 and 25 years. It originates from the periosteum of the sphenopalatine foramen. The pathology it's consists of fibroblasts and numerous blood vessels. Either it's a well-formed feeding blood vessel, or it's a sinusoids, blood spaces between the fibroblast. Usually it have no muscle coat in their wall, leading to easily to bleed. It will bleed easily on touch, and it will be very hard to control this bleeding, as mostly blood vessels, they have contractile tissue and the muscle coat, but the lack of this contractile tissue will cause bleeding that will be hardly to be stopped. Spread mostly local by expansion and erosion due to pressure necrosis, not by infiltration. The erosion here will be just pressure necrosis by the expanding mass. So it's not a malignant infiltrating mass, it just expands, and by its pressure it might erode surrounding structures. It extends from the nasopharynx through the sphenopalatine foramen to pterygopalatine fossa, then to infratemporal fossa. It will cause cheek swelling and might extend through the inferior orbital fissure to push the eye outward, causing proptosis. No lymph node metastasis, as it's a benign tumor. Clinically, there's different symptoms classified according to the group. So to start with, the nasal manifestations, epistaxis. It's a severe and recurrent attacks of epistaxis. This is the most prominent symptom and the most irritating symptom. The bleeding is profuse. It might be extensive that the patient might need blood transfusion. It may be fatal. Also, this patient, due to repeated blood loss, might be anemic. Also, nasal obstruction. First, it is going to be unilateral. If it's extending to fill the nasopharynx, then it will be bilateral. Also, facial manifestation, when the mass extend into the nasal cavity, causing broadening of the nose, pushing the eye outwards, causing proptosis, push it outward and laterally. So it's a metaphor that we say it's frog face. Also extending to the cheek will cause a cheek swelling. The ear manifestation due to encroaching over the Eustachian tube orifice, it will cause its obstruction, leading to recurrent attacks of otitis media with effusion and hearing loss, which is mostly conductive. On examination, the external examination by observing the face, the eye, if there is proptosis or no, and any swellings in the face or the cheek. Nasal examination, the cold mirror test if there is nasal obstruction. Actually, it's not that it's not that important. But the most important is examining the mass by anterior rhinoscopy or nasal endoscopy. We'll see a nasal mass. Posterior rhinoscopy could be complementary, but the main now we use that is nasal endoscopy. Also, if the mass is extending to the oral cavity, reaching the oropharynx, pushing the soft palate downward, this might be a finding. And to conclude it by completing the head and neck examination by the ear examination, where there is bilateral otitis media with effusion and the conductive hearing loss, starting with the tuning fork test, and further we might need some audiological evaluation. Investigations, we will take one step further. For this patient, the CT scan, mostly it's a high resolution CT scan. If there is a contrast enhancement, will be beneficial to show the extent of the tumor, the vascular nature, and usually there is no bone infiltration as it's benign tumor, but expansion might be different findings, pushing the surrounding structure due to expansion of the nasal mass, starting from the sphenopalatine. Sometimes it might push the posterior wall of the maxillary sinus, push it forward. So this is a common finding at the CT scan. Sometimes it's called the Holman-Miller sign. Carotid angiography. Actually, it's beneficial to detect the feeding vessel, usually ascending pharyngeal or maxillary and sphenopalatine artery. The ascending pharyngeal and the maxillary branches from the external carotid. The sphenopalatine artery is a branch of the maxillary artery. Determining this feeding vessel is important as preoperative, so we can prepare this patient by embolizing the feeding vessel before the surgery. This embolization will minimize the bleeding and will make this operation will minimize the blood loss, will make it we can reach up to complete excision of this mass, as troublesome bleeding will be a difficulty to conclude this operation. But there's some complication that might happen due to this embolization procedure, as embolizing this vessel, sometimes this material used to embolize this vessel might dislodge and might cause stroke due to occluding some of the intracranial vessels. Sometimes it might reach to the central retinal artery. It might lead to blindness. So this is some of the complications of embolization procedure. It's beneficial, but with some risks. If sometimes accidental, this might happen. So it's a complication that could be that we can face it during our procedure. And the pure tone audiometry to determine there is conductive hearing loss, and the tympanometry for the effusion it will be type B tympanogram with a flat curve due to presence of fluid in the middle ear. And biopsy should not be done. For the risk of severe fetal bleeding, doing it at the clinic or done under local anesthesia, it will be a risky procedure and very hard to control, sometimes impossible to control. Operation theater must be ready, and for any settings to deal with this patient, as this patient might be it's expected to lose a large amount of blood, and also it must be prepared for the possible need of blood transfusion if bleeding started. It will be very difficult to control. The treatment: only surgical excision after preoperative embolization of the feeding vessels. Different approaches might be there. Now, usually we use the endoscopic sinus surgery. There's transnasal procedure. Using the endoscope, we can determine the extent of the tumor, and with various instruments, especially if there is no severe extension of the tumor to the infratemporal fossa. Sometimes extension to the pterygopalatine infratemporal fossa, we need a wider approach, sometimes accessible by the endoscope. Sometimes we need different approaches, like transpalatal, by incising the palate to expose the nasopharynx for wider exposure. Sometimes we reach the approaches that's used mostly for the malignancies, like lateral radioanatomy by an incision in the face beside the nasal bones for bigger exposure, and the midfacial degloving, which is like exposing the nose by through the oral cavity, by separating and degloving of the middle part of the face by incision through the gingiva, and separating it from the nose for wider exposure of the nasal cavity, which is now less commonly used due to the use of the endoscopic surgery and the use of various tools. It might be possible to excise this path completely endoscopic. So after concluding the benign tumors, we'll start the malignant tumors of the nasopharynx. With the nasopharyngeal carcinoma, we can consider a scheme for any malignancy anywhere in the body by determining age and sex predilection, any racial predominance, any predisposing factor. So we will find the special criteria for any malignancy. For our head and neck malignancies, here as an example, we start for the nasopharyngeal carcinoma. The age and the sex, more in males. It has two peaks, the 20s and the 40s. Racial predominance in China and Southeast Asia, mostly environmental and genetic factors. Sometimes some genetic studies that some families might be more susceptible to have these gene mutations, and further studies are to be concluded at this point. And the most important is the predisposing factor, which has a specific criteria here at this malignancy, which it has the presence of the Epstein-Barr virus, which has an oncogenicity. It will alter this mutation and this neoplastic changes to the nasopharyngeal nasopharyngeal mucosa will develop into a nasopharyngeal carcinoma. So it has a direct effect, and it's also we can use the presence of the DNA of the Epstein-Barr virus and the antibodies to as a part of the diagnostic steps for this malignancy. The pathology will have carcinomas, lymphomas, sarcomas, and chondromas. The most important is the carcinomas, with the anaplastic carcinoma, the lymphoepithelioma, and our main topic now is the squamous and transitional and adenocarcinoma, which is the commonest, and also lymphoma as a part of any head and neck lymphoma, and also multiple myeloma, which is develops from the bone marrow, sarcomas as rhabdomyosarcoma and fibrosarcoma and chondrosarcoma, on to conclude by the chondroma, which arise from the skull base. For the pathology, considering macroscopically, we can find a mass that might be a fungating or ulcerating mass. Sometimes it might be bleeding, some bleeding which is not too severe bleeding, might be due to ulceration of this mass. The spread will be either one of three ways. To start with, the direct spread. If you are trying to figure out the direct spread, you have to think anatomically of this region that have this malignancy. So, if it's spread to the anterior, so we have the nasal cavity, and if it's a little bit lateral, we reach the orbit, starting from behind where we can find the optic nerve, which is the most closest structure. So, reaching the orbit and affecting the vision, and for the nasal cavity, leading to nasal obstruction, and the mass will be eroding many structures in the nasal cavity. Posteriorly will be to the vertebrae, downward or pharynx and soft palate, upwards the skull base and the petrous apex, which have the trigeminal nerve and the abducent nerve. Will erosion of this petrous apex might be determined by affecting the trigeminal nerve, will lead to hypothesia of the face, losing sensation to the affected side of the face, to the same side, and the abducent controlling the lateral rectus will lead to squint. So, also spread upward through the foramen lacerum will reach to the cavernous sinus, leading to paralysis of the third and fourth and sixth nerve, will lead to ophthalmoplegia, external ophthalmoplegia, total paralysis of the eye movement, and also through the jugular foramen to the 10th and 9th and 11th and 12th, the last four cranial nerves, will lead to jugular foramen syndrome with paralysis of the soft palate and paralysis of the vocal folds, and the tongue by affecting the 12th nerves will during the head and neck examination we'll have to check for the all of the cranial nerves for as a proper part of our examination. Well, to complete this examination, we also have to check the neck for the lymph node affection, which is a common way of spread, and it's very early to the upper deep cervical group, especially by starting by the submandibular lymph node, which is just behind the ramus of the mandible. It's mostly in 70% of the cases with lymph node spread, it will be affecting this lymph node. It will be enlarged and will not be tender or painful. It might be the first presentation, as the nasopharynx is considered one of the silent areas to have a head and neck malignancy without any other finding, but the first presentation might be with a neck lymph node that we might consider reaching for its origin to reach for the primary, which might be considered as an occult primary, a hidden primary, if one of the silent areas is affected, which is here the nasopharynx. And blood spread, it's rare, but it's late to the liver and lungs and bones, just as the least the least we have, but we add to the workup for this patient, examining if there is secondaries in the liver and the lung, and any bone aches we might be needing to doing a PET scan or a bone scan. Well, clinically, if we consider the symptoms that the patient might present with, for nasal symptoms, obstruction, which is rapidly progressive over a period of months or maybe more, blood-stained nasal discharge or epistaxis, and with this nasal obstruction, of course, there will be nasal tone of voice, which might be the thing that we move us doing an investigation to discover such a finding. The ear symptoms, which mostly is unilateral, the conductive hearing loss due to effusion, which is we can consider it as a red flag, where any male age above 40 with unilateral conductive hearing loss and otitis media with effusion, we can suspect that something is obstructing the Eustachian tube orifice. Mostly we try to exclude if there is a tumor affecting and compressing or eroding this Eustachian tube. Also, by checking for the palatal movement, if there is palatal paralysis. These palatal paralysis lead to paralysis of the levator palati muscle. Both of these by mechanical obstruction or by invading this palatal muscle will lead to poor dysfunction of the Eustachian tube, and this poor function will lead to otitis media with effusion. Presence of earache could be either due to this obstruction or could be referred earache due to erosion and disturbance by the nervous plexus for the pharynx, which the glossopharyngeal nerve usually causes this referred otalgia. So cervical lymphadenopathy might be the first presentation, as we discussed earlier. These silent areas might be a tricky finding for presenting this occult primary with an enlarged lymph node in the neck, sometimes even unilateral or bilateral. And to end with the most disturbing manifestation by orbital infiltration up to proptosis. Mostly we can also have ophthalmoplegia due to paralysis of the nerves controlling the extraocular muscles, leading to squint, and also to internal ophthalmoplegia leading to diplopia. So it will be total ophthalmoplegia and as external and internal ophthalmoplegia. The neurological manifestation, usually it's the most disturbing red flag that we find. Uh, Mostly this happened due to invasion of the cranial nerve either by spread of the malignancy through the foramina at the base of skull, or by infiltration of the nerve at the skull base. Sometimes spread might be through the nerves. Sometimes it's called perineural spread. Also, by studying each of the affected nerve, the most common is the trigeminal nerve, mostly the maxillary division, which is the second division of the trigeminal nerve. It's the earliest to be affected. Usually, unilateral facial pain is the most common symptom and red flag that we have to check for the cause of this complaint. Sixth nerve will lead to diplopia and squint due to paralysis of the lateral rectus, and of somnoplegia due to paralysis of the third and fourth and sixth. So all of the nerves affecting the movement of the eye muscles affected, leading to ophthalmoplegia, and the jugular foramen syndrome due to affection of the 9th and 10th and 11th cranial nerve, with dysphagia and nasal regurg of fluid, as the palate and the pharynx, the muscles are paralyzed, change of voice and hoarseness due to vagus affection, and accessory nerve will lead to dropped shoulder if the accessory nerve is paralyzed, and the hypoglossal nerve where the muscle of the tongue will be half of the tongue will be paralyzed, so there will be deviation of the tongue to the paralyzed side. Examination: external and nasal, and the neck examination, and the ear examination. So for external examination, the eye, we look for proptosis, squint, ophthalmoplegia by examining the neck. If there is lymphadenopathy, as the number and the size of the lymph nodes to be considered, that will help staging this disease. It mostly can be also bilateral to have lymph nodes bilateral also help in the staging of this disease. Nose examination, starting with the cold mirror test for bilateral nasal obstruction. Anterior rhinoscopy and endoscopy will help seeing this mass with the presence of bloody nasal discharge, and posterior rhinoscopy can be helpful to show the mass. Endoscopy now is the main diagnosis we use, the main diagnostic tool we use to we can see the mass, and sometimes we might be able to take a biopsy probe. Oral examination, there will be fixed palate due to paralysis of the 9th and 10th cranial nerve. Sometimes direct infiltration of the tumor will lead also to the fixation of the palate. Absent palate and gag reflex can be due to paralysis of the nasopharyngeal nerve. The ear examination with the effusion, doing the tuning fork test will show conductive hearing loss, and also the laryngeal examination by indirect laryngoscopy will show vocal fold paralysis, mostly unilateral at the affected side, and the red flag: unilateral conductive deafness and secretory otitis media in a male patient above 40 years old without an apparent cause should be investigated for nasopharyngeal malignancy. This triad will help us in the diagnosis. It's a diagnostic triad, important to memorize it. Usually due to local invasion of the tumor leading to fixation of the palate, and by affecting the glossopharyngeal nerve, and also the vagal nerve as the pharyngeal plexus will be affected, and unilateral facial pain due to trigeminal nerve, mostly the maxillary, and unilateral earache and conductive hearing loss due to Stacking tube dysfunction, and also the levator palati muscle paralysis will lead this to dysfunction of the Stacking tube. This triad could be diagnostic for this nasopharyngeal malignancy. Investigation: a high resolution CT scan of the nasopharynx and the skull base to detect first tumor site size extension, if there is a bone erosion. Cervical lymph nodes can be determined, and the carotid artery and jugular vein assessment, if there is anything encroaching this vascular structure, it will be easily determined. Also, after this, biopsy can be done under local or general anesthesia, can be done using the endoscope as a guidance. Some specific antigens for the Epstein-Barr virus, by detecting the titer of these viral components, it will be help in the diagnosis of the expected pathology, and also to complete the radiological investigations. A PET scan or a PET CT might be helping if there is if we cannot determine the origin of this malignancy, if there is an occult primary with the patient presenting with a just lymphadenopathy. By this PET scan we can determine the occult primary, and also if there is any other secondaries or any other spread, using this PET CT will be effective. Endoscopic examination using either a rigid endoscope, the Hopkins rigid endoscope. It's a straight endoscope. We can use it to reach to the nasopharynx, and the flexible fiber optic endoscope. We can use it to examine the whole head and neck by starting from the nasal cavity to the nasopharynx, if it's possible to reach it, downward to the oropharynx, to the hypopharynx and the larynx, and examining the mobility of the vocal folds to determine if there is any affection of this cranial nerve. Endoscopic examination can be also done in the clinic, which is mostly done, and also can be done under general anesthesia if it's difficult to be performed. And to conclude this at the end by the audiological evaluation for the pure tone audiometry and tympanometry. For the radioanatomy, concerning this is an axial cut of the head and neck at the level of the it's a cut section determining the nasal cavity and the maxillary sinus, and in the middle of the nasopharynx, determining muscles in the lateral wall and the posterior wall of the nasopharynx, with the superior constrictors and the Stacking tube orifices and the fossa of Rosenmoller, and which we assess the possibilities for extension of and erosion of this nasopharyngeal mass, as it might invade the surrounding. So this is also an MRI with different types of images studying this nasopharyngeal space, determining the Rosenmoller fossa, which is the commonest origin for this nasopharyngeal carcinoma. MRI is a very great detailed value, as different studies can be done, and the use of contrast might be concluding, and different modalities that emerge every day for using the MRI can help us detect even minimal lesions and early lesions. Sometimes we can be prior to the diagnosis, prior to examination by endoscopy, if there is some of the red flags that we face for this kind of disease. So this is a nasopharyngeal carcinoma, and at image number A, where there is this is a contrast enhanced study, axial study, showing this swelling with this mark over it at the nasopharynx, with it demonstrates this lesion involving the pharyngeal mucosal space and the retropharyngeal space and the prevertebral space. The tumors makes like an abutment or impression at the skull base on this one. This on the image number B. This is an axial contrast enhanced CT scan with this bone setting. The first one, it was a soft tissue setting. The number B is a bone setting, determining the level of the skull base, and demonstrating if there is any lytic destructive lesion involving the petrous bone and the medial portion of the greater sphenoid wing and the clivus, which is part of the skull base. Another finding for nasopharyngeal carcinoma with a mass including the nasopharynx reaching to the nasal cavity on the right side, and the similar mass. So this radiological findings, they might be negative, and the case might be still suspicious. We should examine and biopsy the nasopharynx under general anesthesia. Sometimes a blind biopsy can be done if there is some of the red flags present, as it might be one of the silent areas with very minimal findings that we can get for this. If we have this red flag like unilateral facial pain or otitis media with effusion at certain ages, we might raise our suspicion and we consider to reach for such a pathology. So the treatment mostly it will be by radiotherapy, chemotherapy to the nasopharynx and to the neck. And there's neck nodes. We have to control this neck nodes by using these modalities. Rarely surgery as nasopharyngectomy for the primary tumor. There is no chance for removal of the tumor with safely margin in the nasopharynx. So surgery, it's not the best option for such malignancy. If the primary tumor is controlled by radiotherapy, but there is a palpable lymph node, sometimes we might need a neck dissection to dissect all the upper deep cervical groups that might be affected by these malignancies, and it's determining the levels to be dissected and resected and sent to the histopathological examination must be carefully planned. Also, this neck dissection to the cervical lymph nodes, it might be indicated if there is if the tumor that planned to be controlled by radiotherapy, there is still a palpable lymph node that is spread to this lymph node might lead to spread of these malignancies elsewhere. Treatment of this effusion by use of myringotomy and ventilation tubes, insertion of a T-tube will help this patient not to develop effusion and affect his hearing. Also, there's the need of follow-up every 6 months if there is no possible lymph node, just to check if there is any lymph node that might appear later on. So the second topic is hypopharyngeal carcinoma, which is quite tricky as due to the tricky anatomy. The hypopharynx is divided into three places, which is the postcricoid area, which is the middle part just behind the cricoid cartilage. Uh, it's uh, it's like the entrance to the esophagus, and there is two lateral triangular shaped gutters on each side of the larynx. It's called the piriform fossa, which is formed by the structures, the cartilaginous structure of the pharynx, it's formed between it and the aryepiglottic fold. It's necessarily sometimes this might reach to the thyroid cartilage laterally and to the aryepiglottic fold medially. To end with the posterior pharyngeal wall. This is a diagram for the anatomy of the hypopharynx, showing these areas that might be affected, with the diagram on the right side, showing a tumor that present at this piriform fossa. As the piriform fossa is a triangular fossa that have an apex, so examining this area is quite important. And different views, lateral views, and posterior views, with no erosions or enlargement of a mass that present. We should check these areas if there is a suspicion for malignancies. Also, another diagram showing the hypopharyngeal space, also detecting these spaces, the postcricoid and this piriform fossa on the pharyngeal wall, pharyngeal wall, might be considered if there is a malignancy, as it might be sometimes a hidden malignancy, as it could be one of the silent areas with no concluding distinctive findings. The predisposing factors, as chronic irritation by the alcohol and smoking. It's a common irritant to the pharynx and larynx, malnutrition, and commonly in females for developing post-cricoid carcinoma. There is the Blumer-Vincent syndrome, it's a common risk factor to be considered for female with dysphagia, as it's sort of the Blumer-Vincent syndrome. There is any whopping in this as this postcricoid area might develop into this hypopharyngeal malignancy, and the age and sex, both old and young ages, both males and female might be affected. For pathology, microscopic, either fungating mass or a malignant ulcer. Microscopically, squamous cell carcinoma is the commonest and usually poorly differentiated, and it's rapidly progressive. Spread is with the same three topics: direct spread to surrounding anatomical structure, lymphatic spread, and blood spread. So directly upwards to the oropharynx and the tongue base, downwards to the esophagus, anteriorly to the larynx, invading the recurrent laryngeal nerve, leading to fixation of the vocal folds and respiratory obstruction, stridor, and or hoarseness. also spread to the trachea, leading to respiratory obstruction, and stridor also backwards to the vertebrae, laterally to the parapharyngeal space and the big vessels in it and the carotid sheath. And the lymphatic spread, which is one of the most common, as this area are rich in lymphatics, so the tumor gives early lymph node secondaries even before the primary tumor is diagnosed, because it's a silent area also, so we need a large tumor to be present to be suspect its presence of malignancy, and the presence by an enlarged lymph node, it's a common presentation for this site. Blood spread is not uncommon to the lung, liver, and brain. The clinical picture, symptoms, early symptoms not usually not present, as early tumors rarely give any symptoms. It's one of the silent areas. Early, there is mostly a vague symptoms, and symptoms that not enough to urge the patient to reach his physician, where this mostly symptoms are significant if the tumor is already extensive. And same situation also in the supraglottic carcinoma, which is part of the laryngeal carcinoma. It's quite a similar pathology. In females having post-recurrent carcinomas, usually it follows the Plummer-Vinson syndrome. For looking for some symptoms, early there might be some vague symptoms like slight discomfort in the throat, sense of a lump or a foreign body in the throat. Sometimes we look for an enlarged lump in the neck, which could be a cervical lymph node, which is this make us look for this hidden occult primary. We can look through the head and neck, and this is one of the commonest, the common silent sites. Even sometimes it could be unilateral or bilateral lesions. Later, dysphagia start to develop. First, it starts to the solid foods, then to semi-solids, and more in advanced stages, reach to up to absolute dysphagia. Pain in the neck with referred earache through the glossopharyngeal and vagus nerve. Hoarseness, if there is dyspnea, and stridor. Also, this is due to infiltration to the larynx or trachea, or infiltration of the recurrent laryngeal nerve, controlling the mobility of the vocal folds. In some advanced cases, affection may be salivation. Sometimes patient, if there is severe ulceration and severe erosions, might have this bad odor in his mouth, with irritative cough, and chest infection might be developing due to sometimes dysphagia lead to aspiration. This aspiration might be to repeated chest infection, and this repeated hemorrhage can be due to erosion, sometimes named as hematemesis. Also, with any malignancy that is extensive, we can find this severe weakness, and we call it a cachexia. On examination, for external examination, the larynx can be pushed forward with absence of the normal laryngeal click when the larynx moved from side to side. This is called the Morey sign. So the presence of a laryngeal click, it's a normal finding. When if it's lost, we consider some certain clinical condition. This is called a Morey sign. With the these causes might be post-cricoid carcinoma, perichondritis in the larynx. Also, if there is any retropharyngeal collection like abscess or hematoma, this will cause loss of normal laryngeal click. And by indirect laryngoscope and endoscopic examination, will show this mass with the ulcer or fungating mass. Also pooling of the saliva in the pyriform due to paralysis of the one of the structures and paralysis of the part of the larynx. Loss of mobility of the vocal folds might be a finding according to the extent of the disease. Investigation, there is three groups. Group number one, diagnose and define the extension, especially expansion, lower extension. We're starting by the plain X-rays. Sometimes they say that the widening of the prevertebral space with soft tissue, shadow opposite to cervical vertebrae, and choice will be going to the CT scan. So a high resolution CT scan to the neck with the lower limit to the lower limit of the tumor and the lymph node enlarged and relation to the vessels of the neck. Barium swallow also will help to detect the site obstruction of the food passage and preparing for hypopharyngoscopy and biopsy under general anesthesia to confirm this diagnosis. So doing a CT scan will be helpful for proper staging and determining the extent of the disease, especially if there is extension to a vital structure or vital vessels of the head and neck. The second group to be done in the investigation is to diagnose if there is operability for this patient with this metastatic workup, starting with the chest X-ray, bone scan, abdominal ultrasound, checking if there is liver secondaries, also MRI, checking for the involvement of the prevertebral fascia, as this is a sign of inoperability. General condition to be assessed prior to GA, general anesthesia, with some labs and ECG, checking the liver and kidney function and a complete blood picture with blood sugar level and determining the respiratory function. Treatment. Here the first choice will be surgery, either for the primary tumor or for the lymph nodes affected. For the primary, we have many choices. There is total laryngopharyngectomy with or without esophagectomy. This is of the lower end of the tumor reaches to the esophagus, and repair to the pharynx, which is a quite extensive procedure. Especially it will need this repair to the pharynx. It might be done using a flap, a mobilized flap, which could be a free flap that moved from some other area to for reconstructing this place, or a rotational flap sometimes be done from a nearby area. And for this lymph nodes also operability, it helps. Radiotherapy might be a different modality with some indication if the patient are refusing surgery or the patient is unfit for surgery, or as a palliative treatment. Palliative treatment also it's a plan for inoperable cases where tumor fixed to the vertebral column and there is lymph node spread and lymph node fixation. Also, some of these measures might be for nasal obstruction, for respiratory obstruction and dyspnea, tracheostomy might be needed. and also gastrostomy might be needed for feeding to avoid any complications. The use of controlling the pain, and sometimes this radiotherapy, it's called palliative radiotherapy, might might be a chance to use for controlling this condition. The prognosis for this hyperpharyngeal carcinoma is very bad, as it's a silent area, so early tumors do not give symptoms, and early symptoms are very vague. These symptoms are significant only if the tumor is extensive, so it's late to be discovered. The area is very rich with lymphatics, leading to early lymph node secondaries, sometimes before the primary tumor is even diagnosed, which is called as an occult primary. Surgical treatment will need a major operation where there is might be add to it neck dissection, either unilateral or bilateral neck dissection, and also a reconstruction of the pharynx is the last step, and also is a very difficult step for this major operation. Patient already, if the patient is debilitated and dysphagia on this patient will lead to some causes of morbidities and mortalities. Tumors of the larynx. To start with, the benign tumors, where there is epithelial tissues like papillomas, which is the commonest tumor of the pharynx, commonest benign tumor. The connective tissues like the angiomas, chondromas, neuroendocrine tumors like paragangliomas and schwannomas, neurofibromas, granular cell tumors, and vascular tumors, which is quite important, and myogenic tumors like lymphomas and myomas. For the start with benign lesions, a single papilloma, it's a true neoplasm, affect mainly adult male. If it's completely removed, it does not recur. Mostly the complaint will be dysphonia, hoarseness, rarely or it's very hard to, if it needs to be very large to cause any respiratory distress or stridor. It needs to be very big. Laryngoscopy will show unilateral single whitish warty like mammillated swelling on a single vocal fold. Treatment is microlaryngeal surgery for excising and histopathology for this lesion. But single papilloma might turn into malignancy in 10% of cases. Just also there's the multiple papilloma or the recurrent respiratory juvenile papillomatosis. Also, it has a viral origin. It affects children from the age 5 to 15 years. Usually, it starts in the childhood and disappears at puberty. The etiology is it's not a true neoplasm, mostly due to a viral infection by human papillomavirus. Pathology it is similar to squamous papilloma of adults, but smaller and sessile multiple, and it recurs frequently and regress gradually at puberty, but does not it does not turn malignant like the single papilloma. The commonest site is the vocal fold, but it may occur at anywhere else in the larynx or the trachea or the bronchi. Sometimes, if the tracheostomy is done as an urgent procedure, it will be implanted at the tracheostomy opening. Complaint would be stridor dyspnea, dysphonia. Laryngeal examination by fiber optic flexible laryngoscopy will show this multiple sessile warty-like granulations on this part of the larynx. extending down to the trachea. For treatment, first is to maintain the airway. If tracheostomy is needed, if there is obstruction, a significant obstruction, tracheostomy carries a risk. If there is this procedure, there be implantation of this pathology by sealing of this papillomata at the opening of the tracheostome, might be even extending to the lower respiratory tract, as this tracheostomy will cause this sealing. This should not be done unless there is severe stridor, and when it's done, it should be very, very low to decrease the incidence of this implantation. Repeated removal by microlaryngeal surgery or laser or cryosurgery is the quite procedure to be started with. Continuation with medical treatment, estrogen interference and tetracyclines and some vaccines might be beneficial, especially if it's involved with human papillomavirus. And the cancer larynx. This laryngeal carcinoma, the incidence of squamous cell carcinoma is the commonest, with 95% of these malignant tumors will be squamous cell carcinoma. It's about 35% of all head and neck tumors. Age usually above 40 years, with a smoker. Younger age can be seen also. The highest incidence will be the 6th and the 7th decade of life. Gender, male are affected more than females. Presence of a precancerous condition is quite important, with leukoplakia, with change into malignant neoplasm. Very, very commonly, it might be needed to strap it off through the larynx if it's possible. It's 50% will turn into a malignancy, and the single papilloma is only 10% will change into malignancy. The etiologic factors and risk factors, smoking tobacco, it's the prime factor causing this malignancy. Only a very, very small amount, like 1% of these malignancies occur at non-smokers. Nicotine has not been clearly shown to be carcinogenic, but lots of components in the cigarette will add to this malignant transformation. The cancer risk is increased with younger age at onset of smoking. If it starts smoking at a younger age, so this risk adds number of years of smoking and the average quantity of tobacco smoked per day. So this on determining this through the history, all this adds to the risk factors. Alcohol intake also will increase the incidence for supragalactic carcinomas. Alcoholics who smoke are thought to carry about 25 to 50 fold increase in the risk of the laryngeal cancer for non-smokers. So the reflux disease, laryngopharyngeal reflux disease, is also condemned for this condition. Some environmental exposures with wood dust, asbestos, and some volatile chemicals, nitrogen mustard, and exposure to radiation. Also immunodeficiency and genetic susceptibility is possible to be considered. And human papillomavirus, some strains has been most frequently demonstrated in laryngeal squamous cell carcinoma. The capsule antigen for human papillomavirus has been identified in about 70% of all laryngeal cancers, with high association with a variant of squamous cell carcinoma called the verrucous carcinoma. Some nutritional deficiencies like vitamin B, A, and beta carotene might be also an addition. Association with some hyperkeratotic lesions like leukoplakia and erythroplakia where there is 3% of hyperkeratosis without dysplasia. The presence of dysplasia will add to this incident. Well, 3% there is hyperkeratosis with no dysplasia at all. 7% with mild dysplasia, 20% of moderate dysplasias, and 25% of severe dysplasias have been shown to be due to invasive carcinoma. Second primary in the head and neck might be either synchronously, with both can be discovered together at the same time, or in 1% of laryngeal cancer as metachronously to be one secondary to the other. This is 5 to 10%. This pre-malignant lesion showing the leukoplakia, which is advisable due to its high risk to be stripped off the mucosa of the vocal folds, and recurrence might be possible, but frequent total removal would be helpful determining what to do next. So there is also non-squamous tumors, which is rare considered, with adenoid cystic and neuroendocrine carcinomas. Well, the pathology on comparison of the supraglottic with the glottic and subglottic. Glottic is the most common, about 70%. It involves the vocal folds present with early change of voice due to disturbance to the vocal folds. Rarely it gives lymph nodes secondaries, as this area is not rich in lymphatics. For the supraglottic, it has some differences. It's the second common place with 20%, involving the laryngeal ventricle, ventricular bands, epiglottis, and the epiglottic folds. Lay presentation, as this area is a silent area, like the hypopharyngeal carcinoma. So these silent area symptoms appear when the tumor needs to be large in size. And this area is very rich in lymphatics, so tumor usually gives lymph nodes secondaries around 30 to 50%, spreading sometimes unilateral and bilateral. 10% with the subglottis starts from glottic region downward to the trachea. Some presentation due to obstruction rapidly seen, giving rise to dyspnea and stridor. So this area gives early presentation. Lymph node secondaries is common, about 10 to 20% at this variant and this group of laryngeal carcinoma. For grading any malignancy, there is a universal grading. Here we explain the use of this TNM systems. T stands for the tumor, N for the lymph node, and M for the metastasis. Well, this makes a unified protocol or way for doctors to communicate with each other, and for classification of the condition and staging and grading of this condition. So T refers to the tumor grade, N lymph node, and M where the secondaries present. So for the T, there is T1, 2, 3, 4 according to the site or an extension of the tumor. Lymph nodes N1, 2, 3 according to the number and the size, and there is if it's bilateral, so number of nodes will help us determine this staging of this, and the M for the mets and secondaries. If there is a presence of secondaries, and also it helps us staging this 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 malignancy. To start with, microscopic could be a mass, fungating cauliflower mass, or malignant ulcer. Under the microscope, 85% is squamous cell carcinoma. It usually gives rise to lymph nodes, and it have a very good response, especially to radiation. Also, there is the presence of adenocarcinoma as one of the rare types to be present. Spread either direct lymphatic or blood. Directly from one region to another, from this could be through the glottis. It's passed from a certain level to another. So if it's in the glottis, it might reach to the supraglottis, or the opposite, from the supraglottis to the glottis. Or if it's in the glottis, reach down to the subglottis. So this is called transglottic malignancy. Okay. Also reaching the erosion of the pharynx, the thyroid cartilage of the thyroid gland is possibility. Lymphatics, lymph node secondaries, the most significant factor in prognosis of laryngeal cancer. So prognosis drops to 50% survival when the patient presents with lymph node with positive lymph nodes, and sites of secondaries. Supraglottic tumors drain to the upper group of the deep cervical lymph nodes, subglottic to the lower group of the deep cervical lymph nodes, and glottic rarely spread to the cervical lymph nodes. Blood rare, about 1% to lung, liver, and bone. Factors determine this lymph node secondaries. The site of the tumor, supraglottic and subglottic are rich, gives rise to 30-50% of incidence. The degree of differentiation, as poorly differentiated, gives more secondaries, and the size of the tumor, which graded by the T system, T3, T4, gives more secondaries. Clinical picture with the complaint were early prostatic carcinoma. There is change of voice, hoarseness, and dysphonia. It's a very early presentation, which is an advantage for any male that's above 40 years with a change of voice for more than 3 weeks should be examined and investigated properly. For supraglottic carcinomas, potentially silent area, small tumors will give no symptoms or vague symptoms, and larger one might lead to obstruction. For this, also the subglottic carcinoma, is the first presentation will be dyspnea, especially on insertion. Later, up to obstruction, up to stridor, due to airway obstruction by this mass. Subglottic and supraglottic carcinomas start to give changes in voice where they reach the vocal. Some images for this sort of malignancy. Well, late there is dysphagia, pain due to deep ulceration and peritontitis, referred upalgia through the ardinal branch of the vagus, fetal oris, bad odor, and cough and expectoration, which might be blood stained, loss of weight, appetite, and cachexia. Also in the past history there is neck radiation or smoke. On examination, external, there is might be broadening of the thyroid cartilage, tenderness due to perichondritis, tenderness over this cartilage, movements. Sometimes the larynx might be fixed, mostly due to extralaryngeal spread, and the Murray sign, looking for the laryngeal click. If it is absent, means post-cricoid association or perichondritis. Lymph nodes, by examining the lymph node groups, which is positive or not. Indirect laryngoscopy, it shows the site and extension of the tumor mass in the larynx, and the mobility of the vocal folds also shows the extension outside the larynx to the piriform fossa or the postcricoid area. Investigations, generally we assess the general condition of the patient, routine investigations for serology, also chest x-rays and pulmonary function tests if it's needed. Radiologically, the high resolution CT scan will determining this extension and cartilage involvement and the lymph nodes affected, and the carotid artery and jugular vein, which is the most precious structure. Endoscopy by direct laryngoscopy, assessing the tumor extension and taking biopsy, usually under GA. Also, this stimulates the cancer, and biopsy will confirm this diagnosis. Determine type of carcinomas and degree of differentiation, as this biopsy will help us for proper staging. And metastatic workup for the chest X-ray, abdominal ultrasound, and bone scan. Treatment modalities for laryngeal carcinomas. It's a potentially curable cancer, especially if there is early diagnosis and early assessment and intervention. This is the key for good prognosis. Curative treatment, either surgical or radiotherapy, or combination of radio and chemotherapy, followed by rehabilitation, which is done after total resection of the larynx, called total laryngectomy. Palliation for inoperable cases. Some signs of inoperability might be distant secondaries, advanced local disease with diseases above T3, T4, poor general condition, surgical treatment, the operations for early cases. Now we can also add the option of irradiation. Sometimes it has good results at early cases, and laser can be an additional tool during laryngoscopy. It has been used with very good results. Supraglottic tumors might need a partial laryngectomy up to total laryngectomy. Advantage of this partial resection, additionally, it helps to preserve the voice with no permanent tracheostomy, and it's worth. This is some diagrams of this malignant lesion, either the glottic, supraglottic, subglottic. Diagrams for different malignant lesions. Well, in case of respiratory obstruction, securing the airway is the most important. Well, tracheostomy procedure is done mostly surgically to secure the airway until planning what's next. For late cases, total laryngectomy is a large operation, and it's not a partial operation. It have indication that there is paralysis of the vocal fold for large tumors with extralaryngeal extension, cartilage involvement. Also, if there is a previous trial by treatment of radiotherapy, sometimes recurrence happen after radiotherapy or after a partial surgery, as total laryngectomies. It's mostly eradicating surgery, and partial surgery sometimes preserves some of the functions of the larynx. Sometimes it might fail, and also there is recurrence that might happen The advantage of this radical cancer surgery, it may carry better cure rate, but with total loss of the function of the larynx, which is loss of voice, and the patient will live with a permanent tracheostomy, limitation of his activities, inability to increase intrathoracic pressure by straining after the laryngectomy. He will not be able to strain with force, and completing this procedure with the use of neck dissection indicated when cervical lymph nodes are involved. Neck indications and neck dissection is done at the same time with different types of laryngectomy. So clearing the neck, it's an important step that must be done for the supraglottic and the subglottic malignancies. After total laryngectomy, this is the laryngectomy specimen on the left side, and this is the permanent tracheostomy after closure of the wound. So this is the laryngectomy patient, and the trachea exteriorized and sutured to the skin, and there is complete removal of the larynx, and the pharynx, which is the posterior wall, will be repaired after removal of the larynx. So the patient will resume oral feeding as normal. Second option will be irradiation. Indications now we do it for early cases with small tumors, with mobile vocal folds. It has the same results as surgery, and it has an advantage of having a better voice due to avoiding this surgical intervention. So also when the surgery is contraindicated, where there is some recurrence, which is hardly to operate, so radiotherapy is a choice. Sometimes lymph nodes with troublesome resection, for troublesome to this patient to reach for the neck dissection, so irradiation is an option. Contraindicated for large tumors with cord fixation, and cervical lymph nodes. There's cervical lymph nodopathy. Mostly neck dissection can be preferred, and cartilage invasion also it's a contraindication for this. It's preferred for this cartilage invasion to undergo a radical surgery, and for lymph nodes also, and large tumors. Complications: skin burn and discoloration, xerostomia with dryness of the oral cavity, and laryngeal edema, and anorexia and malaise, and perichondritis following the radiotherapy. The disadvantages is prolonged treatment needs regular follow-up. This follow-up for residual or recurrence is usually difficult because of the edema produced by this radiation, which makes evolution of tissue is difficult. Palliative treatment for late advanced cases with distant secondary, sometimes surgery, tracheostomy for obstruction, gastrostomy for feeding severe dysphagia, palliative excision for the fungating tumors. Also, for this excision will improve the outcome of the airway. Irradiation to avoid some fungation and relieve pain, and chemotherapy also is an option. Medical antibiotics for infections, and painkiller for there is pain. Prognosis for glottic, it has a very good prognosis due to early symptoms and lack of lymphatics. It has very good 5-year survival rate with 85 to 90%. Others not as good, and they are have late complaint with early lymph nodes to be present. Rehab after surgery. First, for partial resection, some patients need to voice therapy to teach them to how to give a proper voice. Also, if there is a complete resection, there will be esophageal speech or artificial larynx or the tracheoesophageal valve or the speech valve, which is one-way valve inserted in the wall between the trachea and the esophagus after total laryngectomy. A patient closes the tracheostomy by his finger and pushes the expired air through the one-way valve to vibrate the esophageal muscle at the upper end of the esophagus to produce voice to be good to articulate with into speech spoken. The artificial larynx, sometimes useful and easy, sometimes is quite trouble to use. So this voice rehab by the insertion of this speech valve with different kinds of speech valve. Each surgeon sometimes have a preference of the speech valve, so prefer some different kinds over the other, and this is called the tracheoesophageal valve.